All right, so it looks like we have the system up and running here. So this will be the last part of my lecture series. Though we still, remember, we still have half an hour lecture then following this. But so now I'm going to be talking about the inflammatory and neoplastic diseases that we see within the eyes. At least the main disease processes to allow you then to decide what to further investigate as the underlying cause when it refers to the inflammatory conditions. And so just like I did previously, and this will, in this lecture here now, also allow you to get kind of a little review of the normal histology of the different regions around and within the eye. Let's start with the eyelids. And so here I would like to point out the meibomian glands, these modified sebaceous glands that in dogs can very commonly get proliferative. And so again, keep in mind this normal size here as you would be looking for meibomian proliferative lesions. Notice that the regular skin is then what covers the rest, which would basically be the outer aspect of the eyelid. And so any skin diseases can certainly end up affecting the eyes as well, which means that at least these kind of ocular diseases can be seen either by the dermatologist or by the ophthalmologist. So in this particular case here, it is a severe case of demodicosis. So demodex that ended up then also extending to the periocular region. In this case here, it is dermatophyte infection. So again, these were cases contributed by one of our dermatologists who saw these cases. And you may end up then having some secondary bacterial infection that leads to conjunctivitis then in these animals. Here, a case of leishmania. And so that is not really a problem in the United States, but certainly a problem in Brazil, where I come from. And we were discussing in the break session that this was a disease that, because I come from the south and went to the vet school in the southern part of Brazil, we did not really have to worry about. Leishmania for us was a problem from further north, because remember we are in the southern hemisphere, so further north means in the warmer region. Nowadays, it is already autochthonous in the southern part of Brazil as well. So we can certainly see that as, they may want to say what they want, but as the climate is changing, and so you're having kind of warmer time periods than of the year as well, vectors are spreading of different types of diseases, and including of leishmania. And in Brazil, leishmania was always a big deal for dog owners, because as soon as you recognized a dog to be just serologically positive, that meant having to euthanize the dog. Nowadays, they have the possibility of treatment. They were already doing quite a bit of treatment even before it was allowed, but now you have officially the possibility to actually be able to treat dogs like this one here. And this is a dog that comes from the state of São Paulo, where one aspect that was interesting to see is that the dogs, only the dogs that seem to have these eyelid lesions due to leishmania, also then seem to develop ocular lesions per se due to leishmania. So again, it seems like the parasite, if it ends up within the eye, would then really have reached the eye only in those cases where we actually had these periocular lesions in association with skin lesions in general. So they, at least in their experience, have never seen ocular lesions in dogs that did not have at least previous skin disease. Now, this is a skin condition that you would certainly want to recognize as soon as possible, though obviously that will depend on how quickly the owner takes the dog to the veterinarian. It's a skin disease that affects, and we can see the nose here with the ulceration, and there is this periocular involvement, with some swelling, with some alopecia. Then notice also these very red eyes, because uveitis may be seen simultaneously with the skin lesions. And this dog was recognized as having uveidermatologic syndrome, which is what this disease represents, and was then treated And within a week of treatment, already looked a lot happier. So you can see the ulcer is barely visible on the tip of the nose. And we also don't see that reddened evidence of the uveitis in this dog. Alopecia, obviously, and there is then still a depigmentation and so on that may end up remaining. But again, if you have the combination of these lesions, mostly in an Arctic breed of dog, that certainly helps you then to make the diagnosis of uveidermatologic syndrome. I will come back to basically cases where you don't see that combination simultaneously clinically, and so that may then be a little more challenging and make the diagnosis. But what you would be looking for histologically is this very macrophage-rich inflammatory process in the eyelids or any other skin lesion that would be affected, and that is generally very closely associated with the overlying epithelium, may even form kind of a lichenoid type of infiltrate. In this particular case here, in this picture, it doesn't really have the melanin that we generally tend to see within the macrophages, but you will see that as I will talk about this disease again when I talk about uveitis. And there I'll then be showing the intracytoplasmic melanin that we would expect to see with uveidermatologic syndrome. Because remember, that is discussed as being an immune-mediated process that is targeting cells that contain melanin. And these macrophages are then basically picking up the released melanin from those destroyed melanocytes. So here is one of these cases. This is a paper that actually just came out in the latest JAVMA. And it reminded me of a case discussion that we had with our dermatologists, where they submitted a biopsy, a skin biopsy of a dog, where they reported basically these kind of lesions, periocular and nasal, perinasal alopecia, that histologically, in our opinion, look exactly like uveidermatologic syndrome. Now, the dog in the biopsy that we had received had a history of having had that lesion since October of last year, and it was a biopsy that I had last month. And so there had already been several months that went by between the supposed beginning and then the biopsy in that particular case. In this case here, in this particular dog, they pointed out that the dog eventually developed ocular lesions, but it was only 10 months after it had developed these ocular lesions and had been treated for them. So it's something to keep in mind that sometimes you may only see the skin lesions first, and the ocular lesions may follow, but up to a year later. And so you would then still, our dermatologist then pointed out that what can help from a clinical perspective and further supporting this presumptive histologic diagnosis is then exactly what we see very well in this dog is this leukotrichia. So basically this depigmentation of the hair, and you would also have that of the skin. So while the ocular lesions only manifested later, again, we can see basically this depigmentation that goes along with this immune-mediated disease against the melanin. Now, this here is kind of going a little deeper into the eyelid per se. We have this granulomatous type of infiltrate that certainly can extend to the surface, but is not just deep, but then very obviously characterized by all these clear lipid spaces. And I think I have a higher mag here to further highlight the fact that they're not just these large clear spaces, but there are also these kind of small crystalline type of deposits within the cytoplasm of the macrophages. There may be multinucleated giant cells here too, as we can identify here. And if you polarize that, if you get lucky, we have not always been able to repeat this, but this kind of crystalloid material accumulating within the macrophages is expected to be polarizing. So when you see this, this is typical of tear film from those meibomian glands that is being released into the tissue. And so you should be looking for, this is basically what we call chalazion and you should be looking for an underlying meibomian gland lesion that ruptured. So may it be hyperplasia, may it be an actual neoplasm of those glands. That's generally what will then release this lipid-rich tear film that will lead to this very unique type of inflammation. Now going to the conjunctival side of the eyelids. That is a mucosal epithelium, and we can recognize that we have a lot of goblet cells in the lining here. So there we may also see something similar. And again, you would always want to investigate still a meibomian gland lesion in the vicinity. But particularly cats can actually get this type of lesion. So basically lipogranulomatous conjunctivitis, where it's undetermined really what the underlying cause is. If you had some steroid injection or so in the area, that could potentially be an underlying cause of that. If it's not really, if it's more those distinct granulomas, and I may have, yeah, so if it's these distinct granulomas that are centered on a clear space, and that is the type of reaction that you're seeing in the tissue, this may be a process that is similar to the sterile dermatitis paniculitis that we can see elsewhere in the skin of dogs. So again, an immune-mediated process. Some people have associated with Bartonella, and so that's maybe why we don't identify any agent, because we cannot get Bartonella through regular cell culture, aerobic culture. That has yet to be proven. And again, you can have, if this is the type of lesion that prevails, then this presumably immune-mediated lesion, granulomatous / pyogranulomatous response, as we see it elsewhere in the skin of dogs. Now, keratoconjunctivitis Zika, so that will then, over time, when you have this desiccated corneal surface, because the third eyelid gland, generally the one that is affected and basically atrophied, often due to inflammation. So basically desiccation of the surface, then secondary infections, and also a hyperpigmented, often somewhat fibrosed cornea. And you may imagine that a dog that has a cornea that is completely pigmented can certainly not see anything anymore. This is what you may then see histologically. So here we are actually in the cornea rather than in the conjunctiva. But so these pigmented cells should definitely not be there. Melanocytes are a no-no in the normal cornea. We have vessels, and they should also not be present. You can see how the stroma changes. This is the normal stroma, how it changes because it's more fibrotic. And even the surface epithelium is somewhat altered. So this is what chronic conjunctivitis, chronic keratoconjunctivitis would look like. And again, keratoconjunctivitis Zika, where the underlying problem would be in the lacrimal glands, is something to always keep in mind. A question came up, and I think this will be a good slide for me to try to show that, is what corneal edema looks like in the normal section, in the non-affected section. So it is very frequent that we have these clear spaces within the cornea. That is an artifact, but there's an artifact that we will see in a cornea that is not affected by any disease process. So don't interpret the presence of these spaces here as an indication of edema. Corneal edema will lead to a very pale eosinophilic appearance of the cornea, and we kind of get that feeling here. And we don't have as many of these spaces, and I will point those out again as I have a normal picture of the cornea later, as we normally would have. So we have areas where we lost those spaces, and if you were to look at this cornea closer, you could actually see very thin individualized collagen fibers. And so the corneal edema is characterized by the loss of these spaces. And so again, we have some areas where we don't have them here. and by individualization of the collagen fibers that form the corneal stroma. And that means seeing very thin kind of filaments then uniformly kind of throughout those pale eosinophilic staining areas. So that is what corneal edema will look like, and I will kind of point that out again when we look at the normal corneal picture. But before we get there, this is an interesting disease manifestation of Yersinia pseudotuberculosis in goats. And so in the state of California, where they see a lot of goats, they have done a study to just kind of characterize all the disease manifestations. Obviously, enteric disease is the most common. I believe they had about 65% or so of the goats with enteric disease. But in about 5% of the goats in this group of animals, they had animals with conjunctivitis. And you can see that we have some corneal edema, and it seems like we also have some inflammation within the eye. But the conjunctivitis is really the main problem. And here we have a picture of the third eyelid. So here you can see the cartilage of the third eyelid. And we have abundant inflammatory cell infiltrate here and here. And you may be already have recognized these somewhat denser areas that when we look at them closer, those same colonies of bacteria that you also expect to see in the intestine, in the liver, in the lymph nodes, whatever may get infected in these goats, you will also be seeing in the conjunctiva. And so again, it's these large colonies of gram-negative bacteria that are surrounded by abundant neutrophils. And so that is just one of the disease manifestations, often then with lymphadenitis, regional lymphadenitis, that they see. Among other, they also have abscesses, they have some reproductive disease in these goats, but again, enteric disease is obviously what prevails. Just an interesting kind of additional manifestation of Yersinia in goats. Now moving on to other conjunctivitis. This is in a horse, where while it is in a low mag, we can still recognize these eosinophils that are scattered throughout. And so this within the eosinophilic conjunctivitis. So you don't really need that many eosinophils in order to make the diagnosis of an eosinophilic disease in the conjunctiva or in the cornea of horses, cats, and so on. A lot more difficult than making the diagnosis is certainly then defining the underlying cause. And so obviously one of the things to always consider are parasites. And so this is a case where the Habronema larvae were very readily apparent. The eosinophilic infiltrate was obviously quite apparent as well. But with, and where is Larcos back there? We just discussed that telangia is always something to consider that may be in the area. It's remarkable how little reaction that singly causes generally to the animal. You may then just see, and he has a nice little movie of a moving nematode within the conjunctival sac. But it's still something that could potentially be considered if you have an eosinophilic conjunctivitis. So Habronema in horses. In this particular case, it was a cat that had Diarrheafilaria. And so that is always Diarrheafilaria, whether it's Rapins is probably the most likely, the one that only causes skin infection, skin lesions. That is one that certainly can end up causing some conjunctivitis as well. So here, just a close-up to then show that in these cases, mostly if you are in a more chronic stage, you may end up then with more mononuclear type of cell infiltrate, so lymphocytes and plasma cells. Now, one important cause of ocular disease is certainly herpes virus, primarily in cats. Herpes virus can also cause ocular disease in other animals, but in cats, it's where it's a real problem. And I had as a colleague for a while an ophthalmologist who was working experimentally with herpes, with feline herpes, Wendy Townsend, and she was the one who was able to get the very early stage of the disease. So I don't know how easy it is to see this, but it would be linear ulcers that have some branches so that are being described as dendritic ulcers, because it kind of resembles the branches of a tree. That is the very beginning of the keratoconjunctivitis that you see with herpes infection. This actually also highlights the fact that herpes generally comes from the periphery. So we will be talking about Moraxella bovis as an important lesion in the eyes of ruminants, mainly cattle, where the lesion is in the center. You can also see BHB1-induced lesions, ulcerative lesions, in the eyes of cattle as well. It's actually very common in animals that have upper respiratory disease due to the virus. And it would then again be a lesion that would start at the periphery. And so this kind of illustrates that aspect. I think from a clinical perspective, we are more used to seeing kind of this type of manifestation. So in a more advanced state of the disease, where we often have more difficulties finding the lesion. But in these experimental cases, we were actually able to find several inclusions. I think this one here is a very nice one. Here we have another one. And so you can certainly use immunohistochemistry or in situ hybridization to further highlight the virus within these lesions. Because this is really the best way to associate the herpes virus to the lesions. Herpes has very commonly been associated with ocular disease in cats, but just PCR is certainly not enough for you to prove that that is true. A lesion like this, where you have inclusions and where you hopefully can confirm that as herpes virus with in situ or immuno, is the best way to go. Now, cats can also get conjunctivitis that is rich in neutrophils. As we can see throughout all this mononuclear infiltrate, we have a large number of neutrophils. In these cases, you would want to think of chlamydia, as well as then of mycoplasma, so rather than herpes. Now, here we are in that normal section of the cornea, where you can see how frequent we have all these clear spaces here throughout the cornea that is considered normal. And so, while in other tissues, we may take these spaces as an indication of edema, that would not be corneal edema in the cornea. And so remember, it's the loss of these spaces, having a stroma that is lighter eosinophilic rather than being kind of more deeply eosinophilic as we have it here, and having individualization of the very thin individual filaments of collagen is the way to make the diagnosis of corneal edema. So here we are again in a cat, and so here we have and can recognize some eosinophilic aggregates throughout this lesion. This represents the eosinophilic keratoconjunctivitis in cats, which again has been associated with herpes, but that association is still somewhat controversial. And it's very typical to be clinically characterized by these opaque, multifocal, slightly raised foci that can coalesce and so form larger areas that are opaque. So here is a higher mag, and so here the eosinophils are more readily apparent individually. And you may have lesions that may not have that many eosinophils, and that may be a lot more plasma cell rich. If you find some eosinophils, even if not many, it would still allow you to make the diagnosis of this condition. Moraxella bovis. So as I pointed out, this is a lesion that is very typically characterized by the central ulceration of the eye. And so that's because it is, basically you have flies, stable flies often, that are mechanical vector for the Moraxella. And even if the animal were to blink, obviously the center is still an area of the cornea where the fly may be depositing. That's also the most exposed area. And so that's where they would be depositing the bacteria. And so if you were to deal with herpes, keratitis, keratoconjunctivitis, remember that would be a lesion that should have started then at the periphery. Here we have a histologic section where this A basophilic material here along the surface represent the Moraxella. While here we have a cornea that does not have those distinct spaces. So a cornea that is edematous and then also infiltrated by a number of neutrophils. This is a lesion that if you catch it early and give, for instance, tetracycline, long-acting tetracycline, the animals may be able to recover. But there are also situations, and this was a bull where the lesion was just so advanced that they decided to enucleate because the animal just would not seem to regain visual acuity. What I found striking in this case is that when you look at this lesion here, kind of gave me the impression before trimming that the lesion would be quite extensive within the globe. But then after trimming, I realized it was really only very superficial. Certainly enough to completely impair vision in that animal. We already had significant loss of the stroma here that sooner or later may then even have led to rupture, which is not uncommon in these more advanced cases. Again, if you catch these cases early, because the lesion really only remains superficially, and before they would have mounted too much of a reaction, reparative response with fibrosis and so on, they would then be able to recover vision. And you may get back to a globe that looks quite normal again. Moraxella is certainly a bacterium that can also affect other ruminants. These are then generally other species of Moraxella. Here we have Moraxella ovis. So here we have cornea that is severely edematous. We can recognize the red in conjunctiva. Moraxella ovis is also something that can affect wild ruminants as well. So again, a disease that affects different types of ruminants. And that sometimes called pink eye, and we can certainly see why, because it causes this very prominent conjunctivitis. Going a little deeper into the cornea, here we are in the eye of a horse, where we have these regions here that correspond to these aggregates of neutrophils. They're centered on the decimase membrane. This is typical of deep corneal stromal abscesses. And what you would then want to look for are fungal organisms. So here we have them very readily apparent already within the inflamed corneal stroma. And so these fungal organisms generally represent Aspergillus or Fusarium. You really would need culture if you wanted to define exactly what you're dealing with. Again, notice a cornea without those cleft spaces, so an edematous cornea that is inflamed. And generally this inflammatory process, this fungal infection, is a secondary problem to a superficial trauma of some sort. These fungal organisms just by themselves generally don't have the capability of invading the cornea. They need to have a superficial window that allows them to get in. Horses are generally in an environment that is very rich in fungal spores anyway, so that is already floating around in the air, and if you have a wound of some sort in the cornea, they can settle down and then cause these corneal lesions. And they really like the decimase membrane, which makes our life easy, because if you cannot identify fungal organisms in the stroma, you would want to carefully screen the decimase where you have all that inflammation, because that serves generally as a nice contrast to these fungal hyphae. But if you can kind of already pick out some fungal hyphae in the adjacent stroma here, if you really want to get an idea of how many fungal organisms are within the tissue, a fungal stain such as the GMS certainly will help with that. Now, behind the cornea, we may have some inflammatory cell deposits that would lead to what we refer clinically as keratotic precipitates. So these are clusters of inflammatory cells within the anterior chamber that are clinging to the endothelial lining, that is the innermost lining of the cornea. And by gravity, they will kind of tend to only be able to aggregate along the inferior aspect. if you see this lesion in a cat, which is the eye, where this eye is coming from here, you should always think of feline infectious peritonitis, so FIP. These cats can have other lesions within the eyes, and I will show you that in a little bit. And again, if you see these keratic precipitates in a cat, think of FIP. Then an interesting finding on which I was consulted because they were trying to figure out where exactly this agent was coming from, was here from Eduardo Perlman in Brazil, in the state of São Paulo, where all of these structures here represent microfilaria within edematous corneas that these animals had. So these dogs had corneal edema, they had some conjunctivitis, and when they performed biopsies to try to understand what that lesion was caused by, they found all of these microfilaria in the corneal stroma. They had some microfilaria also in the skin. We could identify those in these dogs, but they were never able to find the adult parasite. It does not seem to represent, therefore, then the regular heartworm or dirofilaria. They believe it's probably some kind of microfilaria of nematode that is present in a wild carnivore, perhaps a fox or something, in the area, but they have yet to really understand where this is coming from. If they treat these dogs with ivermectin, and so they can basically get rid of all these microfilaria, the lesion will end up then resolving. So as kind of we're discussing climate change and how that is changing disease incidence, disease occurrence, certainly something to always keep an open mind, because you may come across things that you have not seen before. Now, corneal injury. So generally we have a superficial insult to the corneal stroma that will lead to erosion and loss of epithelium, and that will then allow tear film to get into the stroma, so you will end up with edema. That goes on a little bit, you'll have inflammation, you may have loss of stroma, so an actual ulcer. That will lead to new vascularization or just vascularization. Some people say it's not new because it never was vascularized. And so vascularization would be actually more correct in referring to the ingrowth of vessels from the periphery. If that problem persists, you may end up with a deep corneal stromal ulcer to the point of eventually losing all the stroma, where all that may remain is the desiccation, that thin membrane that you have on the inner aspect of the cornea, and then you're really just one step away from corneal rupture. And at that point, you pretty much lose the eye. Though we have seen one case where the cornea was completely ruptured, but the lens had occluded that rupture site. And so that eye had persisted still for quite a while before they ended up then taking it to an ophthalmologist and they then enucleated. But generally, corneal rupture is a process that sooner rather than later leads to enucleation. So here we have a cornea, again, cornea that is losing these spaces in these areas here, where we have it more eosinophilic and we can start to recognize individual collagen filaments. We can already see that there's some cells here. To some extent, they may represent inflammatory cells. Generally, they represent some fibrosis, and you will then also see some vascular ingrowth already happening. The problem of vascular ingrowth into the cornea is that will not really regress anymore. So once you have granulation tissue developing, if you will, within the cornea, that will just stay, even if you remove the initiating problem. And so that evidently will impact vision. So ideally, you never really let it come to a point where you have too much fibrosis occurring. Now, this is a picture of the decimedocele, where we lost all the stroma, and we're basically just down to that very thin membrane that is lining the inner aspect of the cornea. And this, as I said, is really just a step away of rupture of the cornea. And you can just imagine you have a certain pressure within the eye. As soon as this closure here kind of has an opening, everything that is within the anterior chamber of the eye will tend to just come out through that space. In extreme cases, and I unfortunately don't have the picture of that case, we had a lens that was sticking through that defect. More often than not, we just see the iris as it protrudes through that case. So here we have the Descemet's membrane, this very thin membrane, and the cornea that has some inflammation and edema. It ends abruptly as it ruptured, and the iris then prolapsed together with some inflammation that we already had in the region, as well as then also hemorrhage. So at this stage here, there's not really anything you can do to save the eye. Then enucleation is really the only way to go. Now, I won't say enucleation is the only way to go, because sometimes they still decide to see if they cannot treat the eyes. And so you may end up then with a shrunken eye, basically with a phthisic globe. And even if you were not to recognize that the eye is shrunken, if you notice the Descemet's and how it is folded here, that gives you an idea of how small this eye is in terms of how large it was originally. Because the Descemet's should be spanning as a linear layer the cornea, and so if it is all curled up, that means you had an eye here that is severely shrunken, and so that you're dealing with a phthisic eye where all we can see here now is just fibrosis, even at the level of the cornea, and a lot of hemorrhage, some cholesterol clefts here. And as I said, that squeezed in between uveal tract, that by itself does generally not develop fibrosis. Now, just before we move further into the eye, I would like to point out the episcleral region. So we are at the level of the limbus going into the cornea, where we would have the sclera and the episcleral region. And that is where we expect to see this type of nodular lesion, that is nodular granulomatous episcleritis. So NGE, nodular granulomatous episcleritis, has that name because of the location and because of the typical granulomatous type of appearance histologically. And so this is something that they may try to treat with anti-inflammatories, because it's thought to represent kind of also an exacerbated immune response in that location that leads to this predominantly granulomatous type of inflammation. Now, this is coming back to that case that I had pointed out before, that one dog that I said had the bilateral lesions of this lipid keratopathy and this very thickened sclera that was present bilaterally. And so in this particular case, they euthanized the dog. And so again, here we have the lipid keratopathy, which in this particular case here then was characterized by these cholesterol clefts surrounded by granulomatous inflammation and fibrosis. So these are the eyes that we collected at necropsy, because they ended up deciding to euthanize the animal. We have now the fixed globes with the very opaque cornea, and then this very thickened sclera that you can see is not just thickened kind of on the anterior aspect, but that ended up extending to more or less extend then up to the posterior aspect bilaterally. This histologically was characterized by granulomatous inflammation that has the added characteristics of it being very much centered on vessels. Though, depending on the section, if you don't really have good vessels in your section, this aspect may actually not be as easily identifiable. But something else to look for in these cases is what some people call degeneration of collagen. Now, because collagen is not alive, hyalinization of collagen may be a better way to describe these hyalinized areas here. So a granulomatous response with these areas of basically degeneration, necrosis, and quotation, as well as these vasculocentric areas, is typical of a more disseminated scleritis. So not the nodular granulomatous episcleritis, but of what clinicians may refer to as a necrotizing scleritis. And that needs to be treated a lot more aggressively with anti-inflammatories. And so, because the owners were not willing to take that on, they ended up then deciding to euthanize the dog in this case. And it certainly had those very prominent corneal lesions as well. And so, what the chances were that this dog would have regained vision is certainly kind of open in the air.
Sorry, with necrotizing scleritis, have you seen a pronounced fibrosis to the point where you see so much like fibroblasts that are atypical and trying to decide like, you know, what to call the disease? Like I've had a couple of cases like that, which, you know, it's like, in your opinion, is there fibrosis with necrotizing scleritis?
So the question was if there is significant component of fibrosis within these lesions. And I have to say that at least lesions like this, where we had enough tissue to look at rather than just a small sample where it's always kind of, where you always wonder how representative that truly is of the overall disease process. I have not really, I mean, this really represents the lesion histologically, and so I cannot say that fibrosis was a significant component, but I may just not have seen enough cases to really be able to comment
on these cases
on
that you never forget, and you still think about it like you're not going to see it later, yeah.
But so again, sometimes, and with nodular granulomatous episcleritis, I've also seen pathologists giving morphologic diagnosis and not really worrying what that may represent clinically. And so veterinarians may not really know what to do with the diagnosis that we provide to them if that's not exactly the same terminology that they would use from a clinical perspective. So nodular granulomatous episcleritis, again, rather than just calling that the granulomatous conjunctivitis or so, if the clinical picture and the histology that you have, or in this case here, if you then also have enough of this change here, whether you want to call that necrosis or not, interpret it as such for the clinician so that they will know, okay, this is the disease process that I'm dealing with, therefore this is the type of treatment that I need to pursue. So we need to do our best in communicating to the veterinarian that the disease processes that we are diagnosing, and not just stay to our own little morphologic diagnosis and not allow them then to recognize what actually the disease is. Now, moving into the eye, this is the iris. And so uveitis are certainly very common. And again, I pointed out that is often then what leads to these acquired cases of glaucoma. In cats, one of the common causes of glaucoma secondary to uveitis is what we have represented here, the lymphonodular, lymphofollicular, lymphoplasmacytic, the different ways of referring to this condition, but it's basically an anterior uveitis. So lymphonodular, lymphofollicular, lymphoplasmacytic uveitis, where we have this lymphoplasmacytic infiltrate that may end up forming these distinct lymphoid follicular structures that will then be sooner or later occluding the filtration angles, and that has been thought to possibly represent the exacerbated response to either Bartonella or Toxoplasma. So if you provide this diagnosis to veterinarians, at least in the US, they will generally then do serology for Bartonella and Toxoplasma, and if they identify a high titer for one of these, they will then treat the cat in an attempt to prevent this disease of affecting the other eye and causing glaucoma in the other eye. Because this is a disease that is thought to eventually end up affecting the other eye as well. FIP. So as I pointed out, we can also see internal lesions in these cats, and they will be very typically concentrated on the uveal tract. Because remember, FIP is basically a vasculitis or a phlebitis. And so we would be looking for the main lesions within the eye then at the level of the uveal tract, which is the vascular tunic. And so the lesions at an early stage will be pyogranulomatous with more or less fibrin effusion. At the more chronic stage, it will be very rich in plasma cells. But it's important that you recognize the presence of these lesions here if you decide to do immunohistochemistry, or potentially I have already attempted to do PCR on some of these cases. Because it's really only when you have macrophages, with or without neutrophils, fibrin, and so on, that you have a chance to still identify the virus. If you get to the stage where you have primarily just plasma cells, you can forget finding the virus within those lesions. So I added this to my presentation just to point out that sometimes we have the effusive form that is characterized in the eye by the presence of all this protein within the ocular chambers. More often than not, though, the FIP manifestation in the eye is associated with the dry form that is also then more commonly the one that affects the brain. And so many of these cats have also cerebral lesions, and again would not have the effusive form with this proteinaceous fluid even in the ocular chambers, but would have more the dry form, where just this inflammation prevails. And it's then when we have that pyogranulomatous inflammation that we then can identify the virus as we have it here by immunohistochemistry. Again, don't disregard FIP if you have a plasma cell-rich infiltrate just because the immunohistochemistry isn't generally negative at that stage. Now in horses, what often sooner or later leads to glaucoma as well is the equine recurrent uveitis that has been associated with leptospira infection. And this is the most extreme case that I've seen. We took the lens out to better show all of this material here that is present at the level of the ciliary body. That histologically then corresponds to this eosinophilic acellular material that covers the ciliary body, that if you stain it with congurat will be positive, and so has basically then be characterized as amyloid type of material. Here this picture shows the three types of changes that ideally we would have to make the diagnosis of this disease histologically. So this amyloid-like material, these eosinophilic crystals within the epithelium of the ciliary body, and then some evidence of inflammation through these plasma cells. Inflammation may not be very striking because they generally have kept treating these eyes, and so it may then be at the stage where the inflammation is minimal. So these other changes, the crystals and this amyloid-like material, would then be more easily identifiable. Now coming back to this dog here to talk about the intraocular lesions. As I said, in this particular case, it was a dog where they submitted the skin. And so this was a different dog than the one we just saw, because we obviously are looking at the eye of that dog. And you can see there is a lot of effusion within the eye. And I don't know how easily you can recognize, but because of all this effusion secondary to the uveitis, this dog already had retinal detachment. And so retinal detachment is a potential sequela of this type of uveitis because of all this proteinaceous effusion. And then it's not really possible to revert, even if you end up being able to get rid of this inflammation. So this inflammation, again, represents a granulomatous, so macrophage-rich inflammation, with the macrophage generally being laden with melanin, to a point where I've already seen people misdiagnosing this as melanoma. Dogs don't get the diffuse iris melanoma that we see in cats. So if you have an infiltrate of round cells that have abundant cytoplasm and are filled with melanin and that are pretty much only in the uveal tract, this is uveidermatologic syndrome. So don't, what they have done in those cases where they were not convinced is that immunohistochemistry with a macrophage marker. So you can certainly always do that if you still have any doubt. But the lesion distribution and the characteristic of the infiltrate is very typical in these cases. And so here we have a higher mag. Again, we can see the tombstoning that basically already indicates that this dog had detached retina, and then this infiltrate with a lot of macrophages, and it's this fine dusting that is very typical then within these cells. And that's also what you would then expect to see in the skin. Now, we can also get infiltrate where macrophages, lymphocytes, plasma cells, and so on are an important component as a result of lens-induced uveitis. And so this slide here is to basically highlight the fact that lens-induced uveitis, where we have a reaction to the lens protein, can be either because of leakage of lens protein without rupture of the capsule. And we see that, I think as a best example, in dogs with diabetes, they can get severe acute cataract and basically then have loss of the leaking lens protein, eliciting severe inflammation that is characterized by lymphocytes and plasma cells within the uvea, and then by macrophages then in the innermost aspect. If we get lens rupture and we have phacoclastic type of uveitis, we will see the added feature of neutrophils that will actually be more closely associated with this lenticular tissue that got released. So depending on the infiltrate, you would then want to look for evidence of rupture of the lens. If not represented in your section, maybe you would want to go back and get another section to hopefully find that rupture site. So here we have an area where we have some cells within the lens, indicating that this rupture here was definitely around long enough for the beginning of phakitis. And because the lens capsule is very elastic and stretched, as soon as you rupture that, it is very typical that you then get this curling up of the ends. Now, just the curling up is something that we have seen as an artifact during trimming. So it's certainly always nice to then see some additional indication that that rupture had occurred previously. And while it is believed that because the lens forms in an encapsulated way very early in the embryologic development, that the body is not really able to recognize the lens protein. And so as soon as you get a defect and that lens protein gets released, you get inflammation. And that would be kind of because it's a foreign protein. A paper in VetPath that came out, I think last year, highlights the fact that you may sometimes, perhaps because iatrogenically, and they have seen that in ToxPath, where they have injected rabbit globes and have by accident nicked so basically caused a localized rupture of the lens capsule, they still did not see any inflammation. And so they point out that the rupture actually needs to be quite prominent. The space, the open space that it would be creating in order to elicit inflammation has to be quite significant, that just a little tiny rupture in the lens capsule by itself would normally not lead to inflammation. So they have put that kind of overall theory that lens protein is always not recognized by our immune system kind of somewhat in question. Here we can nicely see basically nice open large window here. Lens capsule comes here and then it stops. And all these neutrophils are attacking the edges. We also have inflammation that is targeting this released lens material here. So there is certainly no doubt that this one here is a real lesion. With neutrophils, again, being the innermost kind of cells that we expect to see, then macrophages, and if we go to the uvea, we would then see lymphocytes and plasma cells. So phacoclastic uveitis. Now, if you treat these globes aggressively, you may end up then really being able to get rid of the inflammation, but you may still end up with some fibrovascular tissue as we have it here along the anterior border of the globe. And if this spans the filtration angle, you would end up then with secondary glaucoma. So here we have an extreme case, and we just looked at a case over lunchtime where there was downgrowth of epithelium. So here we have squamous epithelium within this globe that also has a lot of neutrophils. So this is basically a bacterial infected globe that had a corneal puncture that allowed epithelium to downgrow and reach the inner chambers. And Dr. Davis-Thompson compares the ocular environment with cell culture. Once you get there, basically have all the nutrients, all the oxygen and so on that these cells would want. So they basically then just get wild and grow wherever they can. And so that ended up then, together with the supportive connective tissue, completely occluding the filtration angle. And so ended up then leading to enucleation of the eye. And phthisis bulbi may then be the end result in those cases. Again, if you don't enucleate them at an earlier stage, you may end up then basically with a globe as we had seen it before. Now, coming to the retina, inflammatory processes of the retina per se are very uncommon. Generally, it is basically secondary to inflammatory processes that affect the choroid. And so one important group of diseases are the systemic fungal diseases. In this case here, there's a cat that has cryptococcus. You can see it starts in the choroid. So remember, this is the vascular tunic. If you have something circulating within the body, it will lodge in the eyes within the vascular tunic, within the choroid. From there, it may end up breaking through the lining here, the retinal pigmented epithelium, and end up in the subretinal space, and sooner or later then also affect the retina. And so different type of fungal organisms, depending on where you are. Again, Cryptococcus, histoplasma, and certainly cause these kind of lesions. Here we have Coccidioides immitis, which is a very important fungal agent in the southwest of United States. Blastomyces is something that is important for us along the Mississippi and Ohio River Delta. In Brazil, it would be Paracoccidioides. So basically any fungal organism, as well as also ProtoZika, which basically behaves like a fungal organism. And so in this particular case, it is PES staining of ProtoZika. Here we already have it within the retina. It generally then comes from the choroid. And here we have what these lesions will then look like in an advanced state. But they will always have started with a choroiditis or chorioretinitis leading to retinal detachment, and if it goes on long enough, you end up having the lesions then also affecting the anterior segment. So if you see chorioretinitis, you should be investigating an underlying systemic disease. Fungal organisms are the most common ones to do this kind of lesion. Though inflammatory processes can certainly happen behind the eyes as well. And so here, the retina is detached but was otherwise normal, as were the choroid and the sclera, and the inflammation is actually behind the eyes. And that may clinically then potentially look like this. Golden retrievers are actually more prone to this clinical manifestation, generally than younger animals and females. We can see that they have this exophthalmia, and this is a typical manifestation of a myositis that affects the extraocular muscles. So through biopsy, this is something that can then be diagnosed, and it is considered an immune-mediated disease, so you would then treat it with anti-inflammatories. An interesting disease that we saw that just reminded everyone of other structures that can get inflamed within the orbit was in this dog here. So this dog presented to our teaching hospital with the history of red eyes. And the red eyes were basically these prolapsed third eyelids. And as they were trying to basically retropulse the eye, because they saw that there was something that was kind of pushing them forward, they were unable to do that. This dog also had diabetes, and so because of the diabetes, it was already older and so on, and they were kind of wondering if maybe there was neoplasia that was causing the ocular lesion. They euthanized the dog. It actually had zygomatic gland lymphadenitis. So here we have the third eyelid that was inflamed on the outer external aspect, but here is this kind of a subgrowth of the tissues in the ventral aspect of the orbit that here are shown in higher mag. And so you can see this is a mucoid, mucus-producing salivary gland that had extensive areas of necrosis, some hemorrhage, fibrin exudation, and some inflammation. There was already a little bit of fibrosis surrounding these areas. So the zygomatic gland is located here within the orbit. Think it's a gland that we often don't think about, but it can certainly end up getting inflamed, and we end up then with the clinical manifestation as we did. So if we have anything around the eye affected, rabbits may get retrobulbar pastorella-induced abscesses. We already had a kangaroo that had a tooth root abscess that then spread. Well, they thought they had treated successfully the tooth root abscess. It actually spread and caused cellulitis within the orbit. Again, anything that can lead to inflammation, even those the myositis that would be affecting then these extraocular muscles, all of that can push the eye forward and cause, therefore, ocular disease. So just something to be aware of. Again, obviously this is not at all a comprehensive list of the inflammatory conditions of the eye, but hopefully it gives you an idea then of what to further investigate. And again, in the syllabus that I gave you, I have, in addition to the terms to use, then also some additional ideas of some additional, basically, causes to investigate. Is there any question before I would move on to neoplastic diseases? That would be the very last aspect to cover. And so, again, just like I did before, start with the anteriormost aspect of the eye, remembering that skin diseases can end up affecting the eye or lead to enucleation. And so here we have a sarcoid. They're certainly quite tricky to treat when you have it so close to the eye. So while the eye per se may be fine, it often ends up being a reason for enucleation, just so that they can get a better surgical margin of this type of lesion here. So here we have the histologic appearance. Again, it's basically a fibroblastic proliferation that interacts with what is classically described as a picket fence type of appearance with this hypoplastic overlying epithelium. Now, what in dogs is very common are these meibomian gland lesions. They can happen, they can occur on the upper and lower eyelid, and they can certainly, I mean, as long as you have meibomian glands, they can occur. So it's a lesion we may see multifocally. In this case here, it's this little lesion that represents this neoplasm here, where you can recognize already in the low mag all the sebocytes that prevail in this lesion. Often there is a history of, oh, there was a small lesion in the eyelid for a long time that suddenly increased in size, and then they do the surgery. And it always makes me wonder if maybe the sudden increase in size was because we had some lobes of this proliferated meibomian gland then suddenly rupture and induce this type of granulomatous response, and that is the reason for the, again, increase in size and worrying of the owner, and therefore then the surgical excision. Here, just to point out already, and I will come back to that later, sometimes we only may get a very superficial biopsy that looks more like a papilloma, reactive papilloma. It should always make us think of a bigger lesion deeper down, and I'll come back to that again. This lesion here is a little bigger, and actually the biggest lesion that I've seen was about 1 centimeter in size. That was really the biggest that I've ever seen. And you can see a bigger lesion here that is also more pigmented, so it may then raise the suspicion of a melanocytic neoplasm. Those are neoplasms in which, of meibomian origin obviously, we have the reserve cell population prevailing that may have some pigment within the cytoplasm. And so we can still recognize the sebaceous or meibomian gland origin, But again, we have a prevalence of these cells that would then lead to the diagnosis of epithelioma. It doesn't really make a difference from a prognostic perspective. As long as they got the whole lesion, that is all that matters. So while with sebaceous lesions elsewhere, epithelioma may already raise the concern of a precancerous lesion. We don't have to worry about that here. So if you're in doubt whether it's adenoma versus epithelioma, it doesn't really matter for the veterinarian. All that they want to know is benign, and that would be the case for both of these lesions. Now, melanocytic lesions. So if they're thought, if they arise at the level of the haired skin portion of the eyelid, that they are generally benign. And so here we have one that is very superficial. Here we have a higher mag. You would still want to always, if you cannot really count mitotic figures, evaluate nuclear atypia and so on, do bleach. But again, if they are associated with the haired portion of the conjunctiva, they're thought to be more often benign. In contrast to when they are associated with the conjunctival side of the eyelid. And so here we have one that seemed to have arisen from the conjunctival side, and that certainly had more histologic features of malignancy. The most severe case of melanocytic neoplasm that seemed to have arisen from the conjunctival side of the eyelid is this particular case here. So this was the very first clinical picture that a regular veterinarian submitted to us together with a biopsy. And we can see that there is this mass that is ulcerated, and so he got an incisional biopsy to just have an idea what this neoplasm was. And it was diagnosed as a melanoma, and so the dog was referred to our teaching hospital because they did not really know how to deal with this case. The client really, really wanted to save the eye. So they went and tried their best in doing an excisional biopsy. As basically the second surgery, margins were still dirty. So the third surgery that I got then a little later was basically the whole side of this dog. So this was not just an exenteration where we basically would then have all the content of the orbit. Here they already had taken all the bone that was surrounding the globe. So again, basically the whole facial aspect here on that side of that dog is what they submitted to us. It was almost like having the face of a dog looking at you. The margins were still dirty because unfortunately they did not go deep enough. The lateral margins were clear, but the deep margins were not. We ended up getting a fourth biopsy that also included the regional lymph nodes. It already had metastasis in the regional lymph nodes. That was really the last time that we heard about this dog. I don't really know what happened to it. But had they gone, our ophthalmologist said they really recommended doing nucleation at the very beginning already. That would perhaps have avoided that they would have gone to an extreme surgery as we had it here, which, as I said, that unfortunately not held. So they can get really, really aggressive. Now, other neoplasms that we may see are these very red appearing neoplasms that already suggest a vascular origin, just from a clinical perspective. And in a state like Louisiana, where we have a lot of sunshine, it is very common that we see vascular lesions both in the skin and certainly then also in the eye. So here we have one of these neoplasms where these vascular spaces are generally nice and more uniform. Often what we end up seeing with the sun-induced vascular neoplasms are changes like this, where the larger vascular spaces are less common and often more in the center, while we see smaller vascular spaces then extending into the surrounding tissue. And there is kind of a continuum from hemangioma, solar-induced hemangioma, to hemangiosarcoma. So generally when we see some nuclear atypia, mitoses, and so on, we call it a hemangiosarcoma, and that's what we did in this case. Here, if you notice, we have the somewhat basophilic appearance, deeper in the region here. and also this more kind of condensed, somewhat smudgy type of appearance of the more superficial collagen, that is an indication of the solar-induced damage to this area. Horses commonly get angiosarcomas. They're called angiosarcomas often because they don't have very obvious erythrocytes within them. And so one may wonder also about the lymphatic origin rather than blood vessel origin. And so this is one of the cases where we can kind of recognize the vascular spaces. Here we can see them as well. Sometimes they are rather solid appearing though, and so immunohistochemistry, as we did for factor 8 here, can then certainly be helpful in order to confirm this as an angiosarcoma. These ones here tend to be a bit more invasive than the solar-induced vascular lesions in dogs. Here we are in the third eyelid. So this is the lacrimal gland of the third eyelid with the neoplasm. In a retrospective study that was published in Veterinary Ophthalmology, maybe that was also biased kind of sample series, but in 85% of their cases, the tumors were malignant. They saw adenomas, they also had rare squamous cell carcinomas, but adenocarcinomas seem to prevail. And so here we have one of these adenocarcinomas where we can have an idea of the invasive edge that they have. The latest tumor that we saw is what some Japanese described as an atypical form that was a complex type of adenocarcinoma. Just like we see it in the memory tumor, that is what we saw in this location. Now here we have one of those papillomatous type of lesions that I pointed out before. So we can see that also in horses. This is in a dog where we generally see this lesion most frequently. They can potentially be viral induced, and so I added this here to just remind everyone of the cytopathic effect that we expect to see with papillomavirus. That is not apparent here, and that was not apparent in this particular specimen. And so in all of these cases where we do not have any indication of a viral lesion, and particularly in dogs where it is so common that we have meibomian gland lesions, we should always consider the possibility that they represent a reaction because of rubbing due to an underlying lesion, due basically to a meibomian gland lesion. And so if we were to only get this very superficial lesion, we as pathologists always need to point out that there is a chance this represents a reactive squamous papilloma to an underlying lesion that was basically then causing this eyelid to be somewhat raised and rubbing to the adjacent structures, and therefore then leading to this papillomatous proliferation. Now, what is obviously of much more concern is squamous cell carcinoma. And so we tend to see that more in large animals, though obviously cats that have a white skin are prone to developing this lesion too. And I had a dog just I think about 2 months ago where we had a squamous cell carcinoma that was affecting all the eyelids as well. So this is a lesion that can be seen in the eyelids, in the skin region, as we often see it in cats, for instance. Or then here we can see the lesion. It can be in the conjunctiva, or then at the interface here, and can be very small. In horses, it often is in the third eyelid, where if recognized early, you can get it with nice surgical margins. Gets to be a little trickier when you have lesions like this. But ideally, you would still not let it go to a point as we had it in this horse here. I remember when I was a vet student, we had a bull in the pasture that ended up being donated to the vet school that also had a lesion like this, that was basically an animal that was more or less forgotten on the pasture by the owners. And so they ended up then letting the lesion get to this point where you often have myiasis, as we have it here, secondary bacterial infections, and so on. And so this would certainly, the quality of life of an animal with this type of lesion is not at all good. And so certainly should have been euthanized long before this. Because doing surgery here is very tough because it basically already invades not just soft tissues, but bony tissues, and so it's really not treatable anymore. It's a tumor, though, that only metastasizes late in the disease process. Again, if you get it early enough and get good margins, as we often can get it in horses with the third eyelid lesions, that's certainly something that we would always recommend to look for. So here, just a histologic change that also points out that it's kind of a continuum in these lesions. So which is again thought to be kind of predisposed by solar incidents, where we would see hyperplasia, dysplasia, carcinoma in situ, and actual carcinoma, squamous cell carcinoma. So you would then always want to trace the lining to see if you're already in an actually carcinomatous type of state. One thing to always keep in mind that if you're just looking at one section, you may be missing a more aggressive lesion elsewhere. I had one section once that had what still seemed to be an intact basement membrane, but already had invasion into a vessel deeper down. And so if you're going to be giving a lesion of squamous cell carcinoma in situ, you have to be really very careful because that you are not potentially missing a more aggressive lesion elsewhere. Now to the cornea. Squamous cell carcinoma can certainly extend into the cornea, and horses have a very interesting appearance where this tumor is basically just forming an opacity that leads to thickening, but not really to a proliferative type of lesion. And so maybe misrecognized, maybe misdiagnosed as a keratitis, while it actually is squamous cell carcinoma. And then melanocytic neoplasms are certainly very important. They will look somewhat different if you're dealing with a dog or a cat, and horses generally kind of have these more mass-type lesions as dogs do. They can be in the limbus region, as we have it here. More often, they are arising from the uveal tract, and mostly when we have those lesions in the limbus area, we always, here you may have to use your imaginoscope, you always have to consider the possibility that this is actually just an extension of a lesion that is arising within the uveal tract. So here we have a histologic picture. So we have the cornea here with the anterior uveal tract, and then this mass that can potentially end up extending through the filtration angle into the limbus region. And that may be the most apparent, while the actual main lesion is internally. So here we have a higher mag. So they are often very pigmented, and in dogs they tend to be benign. Now pigmentation by itself is not sufficient to help with the diagnosis of benign versus malignant. It's really, you should really bleach, just like I pointed out before in the conjunctival, and basically look for indices of malignancy. High number of mitoses, nuclear atypia, and so on, before you decide whether you're going to call it melanocytoma versus melanoma. This case here indicates one of those where the neoplasm extended out into the limbus region. This by itself should not be seen as an indication of malignancy, because the cells, as they are being drained with the aqueous humor, will end up then just following along that tract and may end up then growing in this region here without this representing actual invasion. So Dick Dubilsik put together this panel to illustrate that the same thing can also happen at the level here of the optic disc region, where we have that lamina cribrosa, some collagen fibers that intersect with the axons of the nerves that are leaving the globe, and where there is then also basically an area of less resistance, so that if a tumor arises in that location, it may just kind of follow along and end up then forming a large mass outside the globe, without this, again, by itself not being a feature of actual malignancy. You need to look at it histologically and see if you can find further evidence of malignancy, which will certainly make a difference. These tumors here will never go beyond the orbit. They may still recur locally if you don't have clear margins, but they would not be expected to be spreading into tissues elsewhere. And so that certainly has a clinical relevance, whether you call it benign versus malignant. Now, in dogs, particularly in cairn terriers, we may see a unique form of melanocytic proliferation that is called melanosis. This is a disease that manifests in this breed bilaterally, but it often occurs first in one eye and then affects later the other. And so this eye here has ophthalmos and also has some black pigmentation that you may be picking up. But this dog has an indication of glaucoma, and again with some hyperpigmentation. So this is one of the conditions that can lead to glaucoma, because this melanocytic proliferation here can really get to the extreme of completely occluding the filtration angle. And it's not just anteriorly, but you can also see that it's hyperpigmented along the choroid as well. So this is called melanosis. And again, in cairn terriers, it will end up affecting the contralateral eye as well. In other breeds, where we may see this lesion too, and I've seen it most commonly in boxers and Labradors, this lesion is generally, for some reason, only unilateral. The group at Michigan State University, one of the ophthalmologists is really interested in characterizing these further. And so we may eventually then understand better what leads to this diffuse melanocytic proliferation. So again, melanosis in dogs. Now, dogs can still get melanomas, malignant neoplasms of melanocytic origin. And so that is what this one here was diagnosed as. You can see there is replacement of the posterior aspect of the globe here. And histologically, you may be able to get an idea that there is some variation of the size of these nuclei here that was then diagnosed and had a high mitotic index, so this was characterized as a melanoma. Now, cats' melanocytic neoplasms are totally different. And so this is the beginning of basically the proliferative lesions that they can get. This one here is the melanosis manifestation in cats, where we get a proliferation of the melanocytes along the surface. And so that will then cause kind of a patchy appearance that may end up being multifocal. And at this stage, it often already has melanocytes proliferating deeper into the stroma, to where eventually you have the whole iris then basically replaced by these proliferating melanocytes. And so here we have the histologic picture of that case, where we have these more or less pigmented cells that are basically just overtaking all that stroma and expanding it. Here is a high mag, and so you can see we may have multinucleated cells. We have some variation in nuclear size. Generally, we have mitotic figures and so on. So that would be a diffuse iris melanoma. And there is a paper where they have looked at several of these to kind of define some prognostic features. Invasion of neoplastic cells into the sclera and into the vasculature makes sense. That this would then be an indication of the potential for metastasis, as well as also more than 7 mitoses per 10 high power fields, extensive areas of necrosis, and extension of these neoplastic cells then back into the choroid. All of those seem to then lead to a higher chance of metastasis in those cats. Now, melanocytic neoplasms, again, that is a very important group of neoplasms. And epithelial tumors, we already talked about those in the eyelid and cornea and conjunctiva. And so now another group of epithelial neoplasms that clinically is often behind the iris, though it would still have iridociliary origin. And so here again, the iris. And so generally it's behind the iris at the level of the ciliary body is where we expect to see the iridociliary adenomas. They are generally benign, so they're very bland looking. They may be pigmented, and so grossly there may be the concern for a melanocytic neoplasm. You may want to do PAS to further identify these neoplasms as epithelial in origin. Though I've seen people misdiagnosing a primary iridociliary adenoma as kind of primary, while it was actually a metastatic mammary tumor. And so be careful that you don't just use the presence of a basement membrane highlighted by PAS as an indication of primary neoplasm, because any epithelial neoplasm will have PAS positive basement membrane. One kind of interesting feature is that these neoplasms are vimentin positive. And so if they are benign, they may only be vimentin positive and maybe cytokeratin negative. And as they increase in potential, kind of where you see more cell atypia and so on, the chances to have a cytokeratin positive staining tumor increases. So some people have kind of said, okay, if you have a dual positive tumor that is iridociliary origin that has a malignant appearance, well, any carcinoma will eventually end up acquiring this dual expression, regardless of whether it is iridociliary in origin or elsewhere, and then metastasizes to the eye. So don't just use that dual positivity as an indication of primary origin for a malignant neoplasm in this location, because again, any less differentiated carcinoma that metastasizes can certainly be dual positive as well. And this is one of those malignant neoplasms. So this one here was histologically diagnosed as iridociliary origin, so basically a carcinoma primary to the eye. Often these cases are seen in globes that are injected, that have been injected with gentamicin. But at least Davis-Thompson believes that it wasn't the gentamicin injection that induced them. He thinks that may already have been a tumor there, and that may perhaps then just have been facilitated, if you will, to grow by the gentamicin. But again, the actual cause of these neoplasms is still undetermined. Lymphoma is what we see in this particular cat here. Certainly the kind of an ocular manifestation of Marek's disease in birds. So just imagine this in a bird, and the Marek's disease would look exactly the same. In cats and in any other species, as in Marek's disease, you would always want to investigate this as being a metastatic lesion, so a stage 5 lymphoma that is affecting the eyes. Though Amy Durham from the University of Pennsylvania, she worked up a case series of what is believed to be just primary lymphoma cases of the eye. And so I'm sure we will see a publication that will then be describing those characteristics in the near future. Lens. So that actually is thought to get neoplastic as well, and obviously in cats, since they are these very unique creatures. So associated with the lens that is ruptured in these cases, therefore it's thought to be a trauma-associated lesion that leads to lens rupture and that eventually will lead to this sarcomatous type of proliferation. Here we have a higher mag of that. So again, you generally only see remnants of that ruptured lens within the lesion, and see sometimes kind of what looks like a fibrosarcoma type of lesion, as we have it here. We have seen a lesion like that also in owls. An owl that had a history of having been traumatized before they rescued it, and it ended up with a lesion that looked very similar in the eyes. So it makes me wonder if you also have other animals that can develop it. And so here we have what these neoplasms can eventually look like. So it's very typical that we have the whole globe affected, or at least that the whole circumference is affected, with only remnants of the lens remaining in the center. And again, many are kind of spindle cell, fibroblastic type of neoplasms. One of the ways how they have associated with the lens epithelial proliferation that is thought to give rise to these lesions is PAS staining. So you can see all of these PAS positive basement membranes throughout, and that's because the lens epithelium will be secreting basement membrane. And so this is one of the kind of supportive indication for the lens epithelial origin. The other evidence would be through immunohistochemistry, such as alpha A crystalline, that is a marker of lens epithelium that will also stain many of these tumors. They can sometimes be more like osteosarcomas or chondrosarcomas. So here we have a weird multinucleated cell that was in this tumor that had quite a bit of osteoid deposition. So while the fibrosarcomatous type is the prevalent, you can also end up with chondro or osteosarcomatous lesions. And I don't have a picture of that, but Dr. Bilzig discusses the possibility of lymphoma arising within these lesions. So it would be the inflammatory cells that eventually can then get neoplastic, and so you have then a round cell neoplasm as a third variant of these lesions. Now, kind of to finish up, we are here in the retina, and so there's certainly some retinal neoplasms. The most common, though overall still rare, would be the gliomas. And so they generally arise at the level of the optic disc and will then often lead to retinal detachment, as we had it in this case. And the dog will therefore be blind. So here we have a low mag of this lesion here. We can see that there was a lot of serous effusion that contributed to the retinal detachment. Here we have a higher mag, and kind of gives the idea that it was arising from the retina, kind of from that region. GFAP staining is generally what helps. Again, one more histo here, and then the GFAP staining. We were a little hesitant whether we could truly call this positively staining of the neoplastic cells enough to confirm the diagnosis of glioma. But we consulted Dr. Bilzig and Leandro Teixeira, who is now the current director of the Coppola lab. And he said that's sometimes all that they see with staining. And they still take this GFAP staining then as an indication of the diagnosis of glioma. So it's a tumor that will remain in that location, but because of the retinal detachment leads to blindness, and so will then eventually lead to enucleation. Now, another important tumor to be aware of is a tumor that arises from the meninges of the optic nerve. And so that would be here the arachnoid layer that we have around the optic nerve. And that can end up looking like what we have in this Wuhan fixed specimen here. So we have this very large nodular lesion. We can kind of get the idea that the optic nerve is kind of crossing this lesion here. Histologically, they can be characterized, or they may be misdiagnosed as an epithelial neoplasm, because they kind of look epithelioid. And so it is, for someone who is unaware of this entity, and something that may be misdiagnosed. So this is the typical appearance of the meningiomas that can develop in the orbit around the optic nerve. A characteristic to look for, and that all tumors will have to some extent at least, is some evidence of cartilage, some chondrite or osseous metaplasia. And so these areas certainly help if one is a little confused in terms of the origin of this case. But one of the Neuropath mystery slides at a ECVP meeting a number of years ago had a case of this where they just wanted to remind all the pathologists again of this unusual appearance of the meningioma in this location. Now, just to kind of point out an unusual tumor, and that is often quite frustrating for clinicians to deal with, is a neuroendocrine tumor that horses develop within the orbit. And so here we have a horse that has exophthalmos, and you kind of get an idea that there is a mass effect in the orbit. This horse had, as I said, this neuroendocrine carcinoma that was nicely confirmed through chromogramin A staining, that is thought to be kind of a paraganglioma that can develop within the orbit and can be quite aggressive. So can end up extending into sinus and into the surrounding areas. And for some reason, this bleeds like crazy. And so to do surgery, it's often already challenging enough to end up just doing an incisional biopsy. If one were to try to even excise the whole neoplasm, this ends up representing quite a challenge from a clinical perspective. So often these horses end up getting euthanized because of these paragangliomas in the orbit. And that brings me to the end of this lecture series. Is there any question on any of these cases? Yes?
You mentioned the melanocytic tumors in dogs, and then you mentioned that malignant melanoma is quite rare, but what's really the diagnostic criteria? You said that they easily go through fibrous lamina, and that we should look at the anisocytosis, anisotrosis, and netosis. With cats, you said it's over 7. What about dogs? Is there something that's like to put your hands on? Because I don't know what's high. You know, high can be.
Yeah, and I definitely don't know. We were kind of, once the discussion arose, not in the eyes, but just in general also in the skin. If you read slides, for those who are reading slides on a computer monitor and have scan slides, the criteria will end up being different than the criteria that I use on my microscope. So since I'm still kind of old-fashioned, if you will, and look at glass slides, it's basically 3 to 4 hypothetical. So basically what we also use in other tissues. So finding mitoses, generally it's really difficult in the benign cases in dogs. And so once you start finding 2 or 3, I generally go back and kind of look again because I end up coming to at least 4 that would then already give me kind of that. And there is that more nuclear atypia. The nuclei are not as nicely in the center and so on. I would have to say that there were a few cases where we were not able to find as many mitoses as we would have liked, but there was significant nuclear atypia to where we were still kind of pointing out this would be then called the malignant melanocytic neoplasm because of the problem with nuclear atypia. So the same criteria that we also use elsewhere. Now in cats, except for those cases where we only have the very superficial proliferation of melanocytes in the iris, I would not make, where we call it melanosis, we say it's a hypoplastic lesion, I would never make the diagnosis of melanocytoma. In cats, I would always assume this is just somewhere in that progression of diffuse iris melanoma. You may be early, or you may be in a more advanced stage of that disease process, but if you let it go, it will definitely eventually then just overtake the whole iris. So there you were then just looking at what are those criteria as you're looking at it from a pathology perspective, then you should kind of point out to the clinician, you should go back and you should really stage this cat because there is a high potential for metastasis. And that's where the 7 mitoses per 10 hydroxyl and so on have arose. So CDC ones most likely to end up with metastasis, or that had metastasis then already, if not the lesion lymph nodes, at least then also potentially elsewhere. But yeah, there I would not make the diagnosis of melanocytoma. Either it's just melanosis, or it's already early diffuse iris melanoma. But now, kind of to those who evaluate scan slides, and I know that you do and you do as well. Yes. So what criteria do you use in these melanocytic neoplasms?
The formulas which you can calculate how many approximately 40x fields you have on the slide. It is dependent on your screen resolution and some other things, I can't remember. But for me, for example, it was 12 size fields on my computer that rates to 10 fields in the microscope. Just calculate the concept.
So some programs measure the area.
Yeah. But actually, to measure the area, it's a little bit one more action to do, so I just calculate. There are formulas, I think they were subject to Corneal Pathology last December or something like that. It's in October, and they have this formulas.
Yeah, and so that is certainly for everyone who may eventually then get to read histology on the computer screen, just something to be aware of, that we have to be careful to take these old prognostic indicators as it then translate them into what is being shown on a computer screen, because it's not a one-to-one type of thing. We have to be a little more careful with that. Yes?
Yeah, how often do you, in your cases, do you distinguish between a melanoma and to differentiate lymphoma in either a melanoma or to differentiate lymphoma. How do you?
And in cat, I assume,
Yes.
is where, because that's where we have run into that problem. And if we are not really sure, we would then run immunohistochemistry.
Immunohistochemistry in order
To basically, what
to
we're
around both of them, fully differentiated. Undifferentiated, yes.
The lymphoid markers generally still work well. And so that is generally what we end up using. And I have to say we had at least one case where the initial diagnosis was as a diffuse iris melanoma. And then as we discussed the case in rounds, the possibility was raised that it could be lymphoma. And so we ran some immunomarkers for that and then confirmed the case as lymphoma. And that certainly changes the thinking for that case. So it's something we need to be a little careful with.
And why did you use chromogramin? In one of the last slides, you used chromogramin.
Because we were, or I won't say we, this was a colleague of mine that had this case, so she was not aware of this neuroendocrine tumor that horses can have in the orbit. Obviously, she had noticed this very characteristic packeting appearance that suggests neuroendocrine, but then also to provide a diagnosis with most certainty to the clinicians, they were willing to pay for the immunohistochemistry, and so chromogramin is the same as
I was thinking also similar to the scene.
And where is August? Do we have symptomatizing in our lab? If we do, I've never asked for it. I'm generally go for chromogramin because that just goes so well.
Chromogramin A.
Yeah.
And it's also always better to use a coverage A and B. And then we have synaptophytes. And anything we don't have in our lab, it is in the other lab. Because we got two laboratories, ours and the one was working with.
But yeah, so I generally use it. But it should be positive for any neuroendocrine marker. As I said, from a clinical perspective, mostly if you have the impression that a veterinarian is not aware of this condition, it's important to point out that for some reason, I don't know if that's neuroendocrine nature or so, that makes these tumors being very prone to bleeding. And so again, that can certainly then represent the challenge as you try to do surgery and potentially then trying to get more of this neuroplasm. Generally, these horses end up being euthanized because the sinus involved and we have the brain right there and so on. It's just too much to be approached surgically. Any other question? You have my contact information on the syllabus, so don't hesitate in reaching out to me by email or something. I think I may even have my cell phone there, so I would be reachable by WhatsApp if you have that. So certainly feel free to do so, even sharing images or something like that to consult the cases. So, all right. Hope I gave you at least some more interest in ocular pathology through these briefs.